Good afternoon, good morning, wherever you may be. Thank you all for joining us. We'll give it a couple of more seconds for folks to get in and get their audio connected, and we'll get started. All right. Let's get started. Good afternoon, good morning, depending on where you're joining us from. My name is Dafina Ward, and I'm the Executive Director of the Southern AIDS Coalition. And on behalf of all of us here, I would like to welcome you all to this session on Southern communities as part of AIDSWatch 2021. So there's going to be a whole lot of us in this space, and that's really exciting. It looks like there's nearly 80 people who have joined for today's session, and we're so glad that you did. So in lieu of us spending time really laying out agreements for our time together, vocally would welcome an opportunity for folks to throw things in the chat, and please utilize the chat during this session. So our agreement really is just, we want you to come into this space with a spirit of empathy and focus and compassion, and really a focus on self-empathy and showing yourself some grace. And so taking the time to take care of yourself. We know that Zoom can be exhausting, and it's a lot, and we've all kind of gotten acclimated to doing things virtually. But please know that we want you to take care of yourself throughout this process. There's a lot of information, there's a lot of work ahead of us, and we want to make sure that you all are engaged, and if you have questions, if you have thoughts, please utilize the chat, and we will have time to share with one another as well throughout this session. As I mentioned, I'm the Executive Director of the Southern AIDS Coalition, and I greatly appreciate having this opportunity for SAC, our friends from NCAN, and our guests to share with you today as we talk about our work in the context specifically of what it looks like in Southern communities. And this is very much in alignment with SAC's vision, where we hope to do this work that will get us to a place where all Southerners, every person in the region, understands HIV transmission, can receive routine screening and services, and has access to the full range of prevention and care that's needed, including harm reduction services. So to borrow from my colleague, Gina Brown, who always says that HIV stigma is an onion, not an apple, there's a lot of layers. And that is the case for doing work around HIV-related policy in the Southern US. That is the case as it pertains to just addressing all policies that impact those who are living with HIV in the communities that are most impacted and marginalized communities that are often dealing with a range of barriers and challenges as it relates to not just HIV, but all the other intersectional issues that face us. And so we ask you to come into this space. We're going to lift up some key issues that we know that we are battling with and struggling to overcome, and things that we're hoping to achieve in the South in order to improve access, in order to improve availability of services, and just the overall holistic wellness of folks in our communities, and understanding that we're coming with that lens and acknowledging the range of challenges and the intersections that our communities are dealing with. Now, we won't be able to touch on everything, but we hope that you get something from this space that you'll be able to utilize in your work, and we look forward to hearing from you around your work as well. I've been asked to take a couple of minutes just to frame the conversation for today. And so I often use this map, which dates back to the early 1900s, that was created by the NAACP to show folks the impact of lynchings in the South. So we could see the way that racial violence was terrorizing communities in the Southern US. And as you see, those darker shaded states there are in the Southern US. And this is very much connected to the work that we are doing now in the South, as we're working to overcome the disproportionate impact of HIV and other issues on Southern communities, and that we cannot do this work in present day without talking about the HIV epidemic in the South in the context of challenges around medical mistrust, the issues that folks have in accessing the very key services that they need. And so just want to frame our time together in recognizing that many of us are working in rural communities where there is a huge disparity around access to services, around care, and also around stigma reduction, recognizing that there are stigmatizing policies and laws that we're fighting every day, and that many in our communities, more than 39,000 people living with HIV in the South, are pretty far away from any resources that directly address HIV-related stigma and provide support around those issues. That we also have to name the fact that in Southern states, these gray states and these white striped states where there's either no curriculum around sex education, or these states are addressing or requiring abstinence only and not dealing with the full range of comprehensive sexual health education necessary for effective HIV prevention. Also recognizing these orange states, Southern states, many of them that have enacted very strict abortion laws in recent years, challenging opportunities around full reproductive health access and framing conversations around reproductive justice, where we have to recognize the intersections of the range of issues that are disproportionately impacting Black women and poor women and Latino women and others in our communities. And lastly, we're dealing with these, again, gray states, many of them in the South, where there are not protections for LGBTQ plus folks when it comes to non-discrimination, and recognizing how we're seeing that played out now in many of our legislatures, where we see our trans siblings being attacked by laws that are discriminatory and continue to perpetuate discrimination. And so we hope that, in our time together today, that we'll have conversations around some of the key issues that are being addressed through policy work in Southern states. And we hope that if you're not already on the SAC mailing list, that you'll visit our website and join us, and that you'll follow us on social media so we can amplify your work as well. Today's presenters will be Alejandro Acosta with SAC, and then he will turn it over to Lee Stora, Christina Adelike, and then Morgan Farrington. And we're excited to have this time with you all. We'll then go into smaller groups and have opportunity for discussion and sharing. Alejandro.
Hi everyone, my name is Alejandro Acosta. I am the Director of Public Policy and Advocacy for the Southern AIDS Coalition. I apologize for my voice today, but somehow I'm losing my voice. I know that we're surrounded by advocates and people who are very involved in the community, but we also must recognize that we might have community members who have not so familiar with this topic. I'm going to be addressing HIV criminalization in the Southern states. For those of you who do not know, HIV criminalization is the broad use of criminal law to penalize, perceive, or allege potential exposure, non-disclosure of HIV. And especially in the South, this is a problem because we have 50% of all new transmissions happen in the South. The problem with these laws is that most of them have not been updated since 1980. They discourage people from getting testing because they perpetuate stigma. And these laws are also disproportionately used to discriminate against people from already vulnerable communities, especially something like sex workers. For example, in Florida, the Williams Institute reported in 2019 that most people who come in contact with criminalization laws are actually sex workers. Currently, there is an effort in Florida, we'll talk about it a little later, to modernize these laws. So there's different approaches that states can take to modernizing their laws or actually repealing. Unfortunately, in the South, only North Carolina and Texas have either repealed or modernized their laws. Currently, with COVID-19, we have an opportunity for change and to really show momentum on these laws. Right now, most of these laws are trying, the way to modernize it, for example, is trying to change organ donation guidelines. These organ donation guidelines will follow the HOPE Act from 2013 that allow people living with HIV of shared status to share, to donate organs and tissue. In most states, this is still illegal, even though it has been legal almost for 10 years already at the federal level. A lot of these laws also punish people for non-disclosure without proof. So someone can be having a relationship and actually have disclosed, and they can be arrested, prosecuted, and convicted for non-disclosure, even if they actually disclose, because there's no proof needed or necessary. A lot of these laws also criminalize transmission without transmission having occurred. So when you think of a crime, it's so weird to actually convict someone of a crime they did not commit. So you have people being accused of transmission and convicted of transmission who actually never transmitted HIV to anybody, because either their viral load, they were in treatment, they might have been undetectable. For whatever reason, you have, for example, in Florida, we have a cop who was jailed for 8 years for transmission, even though 5 of his victims, none of them actually acquired HIV. Someone can go to jail in different states for a period of up to 30 years, which sometimes exceeds crimes like manslaughter with a maximum sentence of 15 years. So you can go to jail for 30 years for not killing anybody and not transmitting HIV to anybody. And you can actually kill someone by mistake with manslaughter and go to jail for 15 years. That seems unfair. Once again, there's also a way to lower the penalties. A lot of these penalties are excessive for the types of crimes that or offenses that criminalization follows. People are criminalized for behaviors that are negligible or behaviors that do not transmit HIV. For example, behaviors like spitting. Oral sex, which we know is also negligible. A lot of these states require people to register as sex offenders once they have been convicted of crimes related to HIV. So there's a lot of things changed in the South. As I said, only North Carolina and Texas. North Carolina has modernized their laws. We have an example of that later on with Liz Toros. And Texas actually repealed their laws a long time ago. This doesn't matter because still people can be prosecuted through general laws or general criminal laws. So a state does not have to have HIV-specific laws to prosecute people for it. There are still 33 states and territories that criminalize actively people living with HIV. For example, I used to work in Florida here in the state. We have been trying to modernize the laws for about 5 years now. It's important to recognize that this is a long-term process, that this is not a process that can happen overnight. And so when you're thinking of bringing back this maybe to your states and your state capitals, one of the important things that we need to do is literally educate our lawmakers, educate them on actually basic HIV knowledge. A lot of southern states are still riddled by stigma and misinformation, and lawmakers are also humans and they're people. In Florida, currently, we have Senate Bill 1618, which again is extremely comprehensive, but unfortunately leaves sex workers outside. This happens because in Florida, we have a trifecta government with a governor, House, and Senate, all Republican. So again, when we're thinking about bringing these efforts back to your state, you have to think about southern states being extremely conservative, being extremely religious, and being super Republican. So this effort might seem like an uphill battle. But once again, I think that education of lawmakers, making sure that you make friendly relationships with people from impacted communities. So even if the lawmaker is unaware, or even if the lawmaker is unsupportive at some point, you can use their constituents as the reason to talk to them. And most lawmakers want to keep their constituents healthy. And so that's a great way, right? Our commonalities. Everybody wants to be happy. Everybody wants to be like they belong. No one wants to be prosecuted just for existing. Right now, people living with HIV are discriminated against, are prosecuted just for living with HIV. Again, based on knowledge from almost 40 years ago. So it is important that we bring back science. It's one of the things that most of these efforts in criminalization or modernization of these laws are doing, right? So that the science matches the law. Right now, again, most of these laws belong still in the 80s. Only 6 states have modernized overall: Michigan, North Carolina, Washington, California, Iowa, and Colorado. Right now, Virginia is actually, and Georgia, they're actually trying to change their laws currently, including also Florida. So we have 3 states that are currently trying to change their laws. So if you're from any of those states, it's important that you might want to mention these laws when you're speaking to lawmakers. Some of these lawmakers are unaware that these laws are still in the books. So again, bringing up the fact that these laws need to match science, of current science, is extremely important. Again, there is momentum across the South. There's also many ways of approaching criminalization and stigma, not only through the criminal reform process. For example, we have Liz Toros from North Carolina, who is going to speak to us about a project that kind of also deals with criminalization. It also deals with stigma, but it's not from criminal reform. So Lee, I know that you guys are working in North Carolina AIDS Action Network very strongly. Can you give us a rundown of what are you guys working on in North Carolina? And I am going to say goodbye for now. I'm going to leave you guys with Liz Toro.
Yeah, thank you, Alejandro. It's great to be here with the team from Southern AIDS Coalition for AIDSWatch. This is obviously always a really powerful event, and we're excited to be a part of it. Excuse me, even though we're virtual this year. See a lot of familiar faces in the Zoom and in the chat, and hope we're all going to be together in person in a year from now. I'm going to speak about some proactive work that we've been doing both in North Carolina and regionally through the Southern AIDS Coalition related to pharmacist roles in providing PrEP and PEP. And just to give a quick shout out to that work Alejandro was talking about, we are, continue to be involved and supportive of work to try to think about how our HIV criminal laws are set in the South. We felt really empowered and fortunate to have the ability to do a process through administrative policy change to change our HIV criminal law several years ago. And if folks are interested in that, feel free to drop me a message in the chat. Christina or I would be happy to talk about that. So as I said, we do have a new kind of emerging policy issue that I think has really popped up in the last couple of years and been really amplified with COVID, related to thinking through those access points of both PrEP and PEP, post-exposure prophylaxis. One of the reasons that we as an organization really have started to prioritize policy change related to the pharmacist role in distributing PrEP and PEP are 4 of the reasons here on the slide here. We continue to see that there is a stigma around PrEP and PEP, both with physicians and other healthcare providers, and continuing to change those access points and have other medical providers involved in the conversation is certainly a mechanism to help impact that. We also know that for a lot of folks in rural parts of the state, finding a location in terms of a healthcare facility can be really challenging. Having an affirming healthcare provider, having a provider who knows what PrEP and PEP are can be challenging. And, if a pharmacy could be an initial entry point, that can be a really powerful game changer. We've really illuminated and realized in terms of some of our advocacy work on this, and I'll speak to this later, that there's really an opportunity when it comes to post-exposure prophylaxis to think about pharmacists as a place for a prescription and distribution. I think many folks know this, but just as a reminder, post-exposure prophylaxis really has to be taken within 72 hours and ideally less of an interaction when someone thinks they might have contracted HIV. And if that's something that happened, on the weekend, at night, it can be really challenging to get access to your medical provider. And for most folks in southern states, the only way to get a prescription for post-exposure prophylaxis is to get in contact with your doctor and medical provider. So I think you'll see as I go through this brief talk that we have really illuminated and felt that getting pharmacists authority to dispense post-exposure prophylaxis is really even a bigger game changer than a PrEP conversation. The context I say a lot is that, post-exposure prophylaxis should be treated like Plan B. If you think you've had an interaction and are concerned about getting pregnant, you walk into your pharmacy and you get a prescription for Plan B. We should treat PEP exactly the same way. And just also noted, pre-authorization and the role of insurance providers continues to be a challenge in some circumstances when we think about PrEP and PEP as well. Next slide, please. So I'm going to look at 3 states in the South that have been looking at some form of policy change around giving pharmacists authority to dispense PrEP and PEP. 3 in the South, and we'll give a brief context about some other states. And our kind of interests, both as NC AIDS Action Network and the Southern AIDS Coalition, stemmed from realizing that this was a trend happening elsewhere. New York made a policy change on this front. And within the last 2 years, both California and Colorado, through a legislative policy change, gave authority for pharmacists to prescribe and dispense both PrEP and PEP. Next slide, please. I really love this quote from Colorado. Colorado changed its law during COVID in 2020, and largely, as Senator Dominic Moreno alludes to, really because of some of the realizations about COVID. 14,000 Coloradians live with HIV today. That's 14,000 people with compromised immune systems who have increased vulnerability to viruses like COVID-19. Both HIV and COVID-19 disproportionately impact communities of color, which is why this bill is critical to expanding access to preventative medications for those who need it most. He was one of the champions and supporter when Colorado changed its law. And again, I think COVID-19 even further illuminated why across the board, right? I'm talking about pharmacist access to PrEP and PEP here, but why across the board people need different ways to think about accessing both treatment and preventative medication. You know, in the height of the COVID pandemic, it was hard to get access to your doctor about anything besides COVID. It's still hard for a lot of folks. And so, you know, realizing that we've got to think about these gateways to folks to access preventative services was really important. Next slide, please. So we do have 3 states who've made some meaningful progress on this front over the last couple of months. Virginia actually this year passed a bill, House Bill 2079, that broadly allowed pharmacists to initiate treatment on a number of drugs. That included 9 different groups of drugs and devices, and PrEP and PEP was included in that. That bill was introduced in January and actually passed in February. Virginia has a very short legislative session. They are in and out in just a couple of months. The governor signed that bill just a couple of weeks ago, and it will be effective starting early July. I will tell you, in working on this issue in North Carolina, you know, being able to say, hey, Virginia, our peer to the north did this, and then Kentucky, a state I'll get to in a second, and we can go ahead and move to the next slide, have moved on that, is really powerful. I think folks know, you know, many of y'all are on the ground doing work with us in the South. Like sometimes when I talk to a policymaker, particularly more conservative policymakers, and say Colorado, New York, California did this, you get a little, folks aren't all that excited about that. But when you're able to say like our peers in the South are also doing this, that can be really, really compelling. I'll note here, Kentucky, we worked closely with some folks at Norton Healthcare in Louisville to manage and help support through Southern AIDS Coalition this process. The Kentucky Board of Pharmacy, which is an administrative body that under Rule 315.191 1A, as I allude to on the PowerPoint, has some authority to regulate pharmacist role in this, actually filed a rule change in December of last year that was passed by that Board of Pharmacy a couple weeks ago that authorized protocols related to both HCV and then that language on HIV prophylaxis and HIV infection screening. That's directly pulled from the rule protocol that they set. That was passed by their Board of Pharmacy just a couple weeks ago. So within the year, it'll take about 7 months to officially roll out. Kentucky will have authority for pharmacists to prescribe and dispense PrEP and PEP as well. The Kentucky situation is a little unique. I heard a bit of background noise pop in, so always as a reminder for folks, if you can mute yourself, always appreciate that. It is a bit of a cumbersome process through the Board of Pharmacy. I submitted written comment on behalf of the Southern AIDS Coalition as the chair of the Public Policy Committee to this process, and Defina and I really got to closely watch this policy-making process. And it was a reminder that sometimes policy process can be really behind the scenes. The Board of Pharmacy meetings are not super well attended. There are not a lot of people who know about them. And I just say for those of y'all who are advocates in the South, it's a reminder to pay attention to all the different moving pieces and make sure you know what legislative and administrative rulemaking bodies have authority on things like this. Next slide, please. And I'll just note that we are in process about doing some law change on this front in North Carolina that's really, really exciting. NC Action Network and Southern AIDS Coalition have partnered together to build a really strong partnership on this front. We are thankful that AIDS United, through their free initiative, provided some grant funding that's supporting our public education work on this front. I'll drop in the chat once I finish my talk. Defina and I wrote an opinion piece that we're pretty proud of that ran in one of our prominent statewide newspapers, advancing and educating about this policy change. And we're going to keep doing some work throughout the year. We're crossing our fingers, and I'll just share, for folks who are tweeting on Twitter, maybe don't tweet this just yet, that we do have a senator who's the co-chair of the Health Committee, who is a Republican, who's the majority party in the Senate, who is introducing a broad pharmacy bill, and he's going to include language about authorizing pharmacists to dispense post-exposure prophylaxis in that bill, likely within the next 2 weeks, which we're really excited about and we think is going to be a big game changer and exciting thing forward, both to educate our community about these drugs and change access. And I'll just give a quick plug. We're doing a virtual event, our traditional HIV Speaks on Jones Street, sort of North Carolina AIDSWatch Advocacy Day on May 4th, 2021. That's co-hosted this year by both the Southern AIDS Coalition and NCAN. We sometimes have folks come in from out of state, and that can be really fun and really exciting to have kind of outside guests and folks participating. If you're interested in learning about that event, we're going to open registration later this week. You can feel free to drop me a message in the chat or email me at lee@ncaan.org if you want more information on that. Next slide, please. Yeah, so I just want to give a quick shout out. The bulk of these slides and a lot of our work on this has happened with 3 colleagues. Ariana Fisher is a master's student at Duke who's done significant research on this topic and helped inform our work. Michelle Rose is our partner in Kentucky, who helped inform this. And Matt Martin is my colleague at NC Action Network, who did a lot of work to help put these slides together and been a big leader on this topic for us. Those 3 colleagues with myself will be virtually presenting as part of the Biomedical Summit in a couple weeks. Actually, I believe next week. So if anybody's attending NMAC's Biomedical Summit, we're doing a much deeper dive than this talk on that topic. And with that, I will pass it off to my colleague, Christina. Thank y'all so much. It's always good to be a part of AIDSWatch, even if it looks a little bit different this year. Christina, off to you.
Thank you, Lee. All right, I do not have any slides. I like to keep it pretty casual, but again, my name is Christina Adeleke. I use she, her pronouns, and I'm the Policy and Communications Manager at the North Carolina AIDS Action Network. So I'm based in Charlotte, North Carolina. And right now I'm going to be talking about, Medicaid expansion and why it's important. But before I get into that, I have to back up and talk about the Affordable Care Act, which, since it was passed in 2010, it absolutely changed how we do healthcare in this country. Prior to the ACA, folks had very limited options on, how to pay for healthcare coverage. And as a result now, we have been able to allow more folks to have affordable, comprehensive healthcare coverage. Another thing that was important was that it prioritized preventative care. It was able to expand treatment for mental health services, chronic health, substance misuse disorder, which are all important issues that we need to be addressing in our community. And also it prevented denial of coverage for folks with pre-existing conditions, which includes people living with HIV. So the ACA did a lot to be able to transform the healthcare landscape, but we are not fully to the promised land yet. There are people who, are not able to afford healthcare coverage. Right now with the ACA, people have the opportunity to either, when it comes to paying for healthcare costs, they can either pay out of pocket, which is a dreamy reality. They either have private health insurance and or employer given healthcare coverage, or they're covered by Medicaid and Medicare and or Medicare. But there are still folks who do not fit into these categories and they don't have affordable healthcare options, and they fall into what is called the coverage gap. And so there are over 2 million people who are currently in the coverage gap. And, you know, you're thinking, why is this happening? That pretty much falls down to each state's Medicaid program and their eligibility requirements. You know, a lot of times, you know, under the ACA, you know, there are subsidies that will help folks who are lower income, but only folks that are 100% to 400% of the federal poverty line qualify. And in English, that essentially means for 100% of the federal poverty line, that's $12,760 a year. And then 400% of the poverty line is $51,040 for an individual, both of those. So that's not rolling in the dough. Those are not people who are, you know, making a ton of money, but are able to qualify for subsidies in certain cases. But if they make too much money, they're not able to qualify for Medicaid. So they're in this coverage gap. And if Davina, if you would mind putting up the slide with the graphic, it helps better explain it. All right, so as you see, in the bottom here with the arrows, you have the different FPL percentages, and that's kind of what I was going over with the costs. But if you look at the umbrella of people under, you have people that are covered on Medicaid to the left, people on the right that are covered by marketplace subsidies, which is part of the ACA, helps cover health care premiums. But then there are folks that are in the middle, that they make too much to qualify for Medicaid, but too little for the subsidies. And, you know, this creates a problem because people are unable to provide for themselves because they're focused on covering their healthcare costs. And a lot of times, you know, for people living with HIV, it's really important to focus on covering not only their HIV, but their comprehensive needs. And with Medicaid expansion, that would allow for states to expand Medicaid coverage for folks who would be eligible, and they would be effectively closing the coverage gap. When the ACA was created, it was intended to be able to help lower the amount of uninsured folks. But, you know, some states have not done that. And unfortunately, when you look at the map and you look at states that have not expanded Medicaid, they tend to be in the South. And a majority of those states are in the South. The South has relatively higher numbers of poor uninsured adults than in other regions, has higher uninsured rates, and more limited Medicaid eligibility than other regions, and accounts for the majority, 8 out of 12, of the states that opted to not expand Medicaid. And I think it's really important, especially when Davina framed our conversation and put the map up and shows that there are a lot of parallels to the lack of resources and the people that are impacted. And, you know, if you look in the South, there are a lot of people who are people of color. And so when states decide to not expand Medicaid, they are effectively disproportionately impacting people of color, particularly Black people. So that is something to always think about when policies are being passed or not passed, who's actually being impacted the most. And so I have a list of states that are in the South that have expanded. We have Arkansas, Louisiana, Kentucky, Virginia, West Virginia. There are 2 states that are kind of in the South, depending on how you classify Southern states, that have adopted Medicaid expansion, but have not implemented it, and that's Oklahoma and Missouri. And then there are the rest of the states that need or have an opportunity for improvement and can expand Medicaid, which are North Carolina, unfortunately, South Carolina, Texas, Georgia, Florida, Mississippi, Tennessee, Alabama. And so Medicaid expansion, as I mentioned earlier, is super important for people living with HIV specifically, because we are able to not only cover HIV related care, but we're also now able to cover non-HIV related care, which, 30 years into this epidemic, earlier on in the HIV epidemic, we didn't think that we would be at a place where there would be so many scientific and medical advancements to where people living with HIV are having to worry about other issues that are more so associated with aging instead of having to deal with their HIV, which is amazing, but it also costs money, and Medicaid will be able to help provide those resources for folks. And to be able to cover more information as to why the Medicaid program is important to people living with HIV, I believe we have a video to play.
I was a person that was recipient of Medicaid, and I was diagnosed with HIV in 1993. When I was diagnosed, they told me I would be dead in 3 months. If it wasn't for Medicaid, I would not be here 26 years living with HIV.
For the HIV positive community, Medicaid is actually critical. It's because of Medicaid that many of us have been able to stay adherent on our medications.
We're all just hoping to live longer lives and more healthy lives, and it is Medicaid and that little bit of safety net that helps us do that.
I was able to get my college degree, but Medicaid helped me get to that point. And it had not been for that service, I wouldn't have never made it.
When you have people with continual illnesses such as hepatitis, HIV, AIDS, they need to have continual care. They need to have doctors they trust. They need to not put off those decisions because they can't afford them today.
We're working so hard in our community to end HIV. It's impossible if we can't get people into care. The safety net of Medicaid is the most important thing in our lifetime.
We work to equip people living with HIV to be able to talk specifically about the Medicaid program, to be able to engage their community in a way that makes sense to them, and to be able to get the information out there and to be able to increase and improve the health outcomes for their community.
We've been really excited to think about some creative ways to educate the community about Medicaid.
Well, I just want to walk through some basics about Medicaid. We don't want to confuse Medicaid with Medicare.
Well, we've done a couple of different things. With Medicaid, it's not always a topic that people are super interested in. So oftentimes when we want to start a dialogue or conversation, we usually either make it super policy focused and have a training and go through the wonky bits, answer questions. But then sometimes we may just go to a restaurant or a bar and have an informal conversation and be able to gauge people's interactions with the program in a more casual way. And we found that both of those formats actually work really well.
The Port City gets ready to celebrate Pride this weekend. They call the event Rainbows, Doctors, Unicorns.
My favorite event we did, we hosted a town hall that we called Doctors, Rainbows, and Unicorns, really highlighting a conversation about LGBTQ health and the role that Medicaid plays for people living with HIV, for gay, bisexual, lesbian, transgender people.
North Carolina AIDS Action Network is getting people the care that they need by making sure that everyone who's eligible applies and gets it, and then knows how to use it. And then if something goes wrong, and they also know how to pick up for themselves too.
The consumer's voice when it comes to Medicaid is critical because people know what they need. And when other people are making these decisions, you run the risk of the program not working the way that it should, not being implemented the way that it should.
Our Medicaid ambassadors are leaving this program, I think, empowered to be active spokespeople, to communicate about this work.
My conversations now can be much more informed. When I go back to my community, I can take these discussions and spread them far and wide.
As long-term survivors, I'm not going to die of HIV. I'm going to die of something else. Having Medicaid as my fallback is incredibly important. It's what's going to help me to live to be 80, 90 years old, not die of HIV, but get the care I need in all the other aspects of my life.
All right. I will go ahead and wrap up and pass it over to Morgan to take over.
Thanks, Christina. And hi, everybody. I'm not sure if it's morning or afternoon where you are, but it feels like morning for me. So bear with me here. I'm in Northern Alabama. I'm in Huntsville. I'm the founder of a harm reduction organization there. And for those of you who maybe are unfamiliar, harm reduction works primarily with people who use drugs, trying to create some health equity for folks who are marginalized because of substances or substance use. Briefly, I'll kind of go over my history and then what it looks like to be an advocate in that space in the South. Basically, and it also, if you have any questions, if I move too fast or jump over something, please just drop something in the chat. I'll try to monitor that. So we've been, I say we, it's really just me. I've been doing this for about 1.5 years now. I started out doing harm reduction in New Orleans, and that looked like delivering Narcan to people, trying to make sure that people had access to clean syringes and other supplies that they needed to use more safely, encouraging people to get tested, encouraging people to stay in care, helping them find treatment programs if they were so inclined, that sort of work. And when I moved back to Alabama and wanted to keep doing that work, but found out that there was nothing there. So I sort of accidentally started a program. Oops. And now I'm the founder of a harm reduction organization, which is just mind-blowing to me because 1 year ago I was a bartender. So here I am. And Alabama has its regressive policies just like everywhere else. I think we're pretty well aware of that. And I had no idea how to navigate that. I know that being a loudmouth, like, I don't know, thorn in the side of policymakers is not really an effective method. So I just kind of started inviting myself into spaces that I wasn't invited to and trying to be quiet and learn, but also raising questions and raising issues with people who actually had access to information that I didn't, and who had access to people that I didn't. And really, this has looked like 1.5 years of just saying yes to everything, to everyone. And I've been moderately successful for Alabama. Harm reduction and policy work in these rural places looks like being in outreach work, but you're doing outreach on like a personal level where it's conversations and it's listening to people's stories and it's swallowing your pride and your words and your arguments when people don't agree with you, and just kind of remembering that the heart of harm reduction is to meet people where they're at. And sometimes those spaces are uncomfortable. Sometimes that means having to approach people with whom you do not agree, with whom you have nothing in common, people that make you uncomfortable, people that you make uncomfortable. Everybody's not going to agree with you, but you need those people just as badly as anybody else. So sometimes that has looked like me having to go into really predominantly like heterosexual left wing or right wing rather spaces and be me there and be honest about drug use and be honest about, you know, a lot of things about my life and my lifestyle that I'm not really comfortable sharing with those types of people because they would love for me to be in jail or worse, you know? So some of the things we give up in order to be good advocates in the South, I think, are like anonymity and safety, personal freedom is at stake there. It also looks like deciding that maybe you're not going to undo multiple generations of miseducation, of stigma, of, you know, substance use and the effects thereof. We can't fix it all. Some people are never going to change. Some people don't want to change, but that doesn't mean that they can't be powerful allies in the spaces that they're in. And I think that that's really important to remember, is that we are not necessarily going to turn just everybody into this wonderful, incredibly empathetic, compassionate, caring individual. And I think that it's important to remember that that's okay. Like, it's not a failure on our part as advocates if we don't make these massive changes, but if the conversations start, that's something. And there's the ripple and there's the snowball effect, and that's really more important, I think, than anything, especially at this point. We know that the South is far behind everybody in a lot of these places, so just get it started. I know that expansion to Medicaid or expanding Medicaid is a big barrier to accessing any kind of care. We also have issues with geography and technology keeping people from accessing care, but we've got to remember that we are creating our own barriers as well. We have to be mindful of the fact that sometimes we sort of cordon ourselves off as advocates when we create spaces that are perceived as being judgmental and are perceived as being just closed to certain types of people. And I think that you know, it's complicated because it's, as a white woman from the South, it feels wrong of me to say this, and I hate to be this, like, I internally struggle with this advocating for like the straight heterosexual white male Christian guy in the South, but I do see that a lot of times those guys aren't accessing care, especially in the HIV world, because they have this perceived inequality. They don't feel welcome in these spaces. And unfortunately, that means they're not accessing care, they're not getting tested, they're not finding out about PrEP and PEP, they're not finding out about syringe access. In the onset of COVID, a lot of the people who use drugs that I encountered stopped smoking their substances and began injecting as a safety measure against COVID. So one of the direct results of that was that I saw a spike in people getting sick in all kinds of ways due to injecting incorrectly and not using clean, sorry, y'all, and not using clean syringes. So you just totally derailed me, Paolo. Anyhow, as a result of that, I had to start trying to figure out how to get these folks that feel like they can't access our spaces and they can't access our care, right? And I don't love it that this is a conversation that we have and that we have to have. But I want everybody to sort of maybe leave here being more mindful of creating spaces that feel accessible to people who make us uncomfortable. before the pendulum swings back really far the other way. And I commend everyone and want everyone to continue doing the work to create health equity for people of color, for people who are, I mean, for everyone, right? I really do want and advocate for strongly the equity and addressing the issues that we've seen, creating access to care for everybody. I just really hope and pray that like we have balance there and aren't going to see an equal and opposite reaction that creates just more of an issue. It's really difficult for me to like voice this correctly, and I hope I'm not overstepping, but it's just an issue that I'm seeing here, especially. Moving on though. Again, back to barriers here. I just want to mention that Alabama in particular, the South in general, we have a lot of the same issues as everywhere else. And I think that a lot of us as advocates need to watch internalizing stigma about being from the South and being in the South. I've been all over the place. There are rednecks everywhere, literally everywhere. There's ignorance everywhere. So like, don't ever let anybody tell you that being a Southern advocate means that you've got a bigger job or a harder job. Just because our states like always swing red doesn't mean that we are somehow lesser than. It means that we have job security. You know, I've got a job to do here forever. And that can either be daunting or it can be exciting for you.
I can listen to you all day, Morgan, for sure. We want to give our audience some space to have some questions right before we go into our breakout sessions. And let me tell you, as I said to you before, don't ever apologize for looking out for the people in your communities, regardless of who they are or what they look like. And that is something that we must reassure, because HIV is not a specific gender disease, and it's not a specific sexual orientation disease or a specific racial disease, right? So anyone, and I know that we have Dafina as our co-host. Dafina, do we have anyone that would like to ask a question? And of course, you can always use the chat box, but of course, we have the option of unmuting ourselves and being on camera. If anyone has any questions for Lee or for Christina or for our fabulous Morgan, please go ahead and take advantage of these amazing advocates. And we are very soon going to, as I said before, jump into our breakout sessions. Well, it seems that I interrupted you for nothing, Morgan, because there are no questions. Actually, I do have a question for you, Morgan. You said earlier today, right, that you ended up leading an organization by mistake. Can you briefly expand on how that happened and what you mean by that?
Sure. So we don't have a whole lot of harm reduction in Alabama at the time that I got back here, which was October 2019. I did some pretty heavy Googling and there wasn't anything except a problem. So I had the great pleasure of having to do like town hall meetings and go around and shaking hands and finding out, kind of taking the temperature of the room regarding naloxone access and policy change, really. I knew that syringe access was not a thing here, not legal and not available. And as far as Narcan, I wasn't sure how people could access it. Narcan being the medication that reverses opioid overdose.
There's a question in the chat box asking you do you have any volunteers? Do you have anyone who's helping you out?
I do have some help. I've got a couple of people that do some community outreach work for me, but honestly, it is all On an administrative level, policy level, advocacy level, it's all me. And we're also not funded. We're not a 501c3, so it's me and donations. So living on student loans and Pell Grants and just kind of making that work. I eat a lot of freezer pizza.
Thank you so
But
much.
yeah, I mean, so I started holding town halls. I had a brief Narcan training that had a really nice turnout, and someone approached me and said we should do this, and so we started. And next thing I knew, oops, I'm here, and I've never been more grateful for an accident in my life. This has been fantastic.
Thank you so much. We have a question from Paolo, who's asking, how does undocumented community fit into these topics? I find that there's so many typical, we remain invisible for a lot of people, right? So we're thinking of language justice as one of the very important policy aspects that we have to address. Especially as a Latino myself, as someone who speaks Spanish, I am very aware that access to this information at times is not available in Spanish for anybody. So part of the change that we must see in our communities is what's happening right now, for example, with myself. I just joined the Southern AIDS Coalition in a position that allows me to have impact. So we must give opportunities to people that are different, people who speak different languages. I come from an education background, right? So that I similar to what you just said, Morgan, I ended up being an HIV advocate because of an oops, okay, here I am. And so we want to make sure that we give people, as I said, voices. And there's, when we think of Mississippi, for example, we never think of Mississippi and the Latinx population, right? Because there's only about 3% of them that are actually in the books. But we know they exist. We know that they're working on the fields. We know that they're as part of their communities. So you have a great point, Paolo. And what we must do is challenge our organizations to, what are we doing? How can you include people, undocumented people, right, who are part of services and who are part of our community and living with HIV as well, as part of this conversation, and just mentioning it and just bringing it up and shaking a little bit the status quo. I had that question for Lee before we move into our breakout sessions. Lee, you live in a state that is similar to Alabama and similar to most southern states. Is very Republican and very conservative. How do you navigate finding supporters for these bills that most people think are controversial? And I'm going to give you a minute so we can jump into our breakouts.
Well, I frequently joke I have a lot of funny stories about talking to Republicans about gay sex and drug use. And when I eventually leave this job, I'm going to do a stand-up comedy routine and share all my secrets to the world. I do think it's about being strategic. And somebody asked me in the chat how the state work connects to federal work. It's about relationships. It's about being persistent. It's about being smart. There are probably some members of our state legislature who are never going to totally get it on the majority side, right? But we found champions who have interest in health. We have a former communicable disease nurse who chairs one of our health committees. We've not been afraid to have the conversations and known that we need to keep it up and build those relationships over time. That's my 60-second pitch on it.
Thank you so much, Lee. That is also right. Our common values, like I said before, we all want to be happy. We all want to be respected. We all want to belong, regardless of who you are, what you look like, where you're from. So we are going to literally randomly divide the group. We have right now 110 of you as part of this conversation. So this is going to be really awesome. We are going to have conversations in smaller groups so that we can hear people's ideas. And then we're going to come back to the main room and we're going to share out. So we're going to be in 5 different groups. So whoever, we're going to have, each one of you is going to have us as a leader and one of us as a leader. And we're going to be taking notes and making sure that we record what you guys want to say, but we would like also people from the group to volunteer to share out, because it's not fun to listen to the same people all the time, right? We want to hear from you guys. So we're going to be 15 minutes in these breakout rooms. You're going to get a little notification when we are about to jump back into the main room. And so please, if you can, I would love if most of you can actually see yourselves and have these conversations. So if you can open your camera, doesn't matter what you look like. We're all at home right now. We understand. So let's go into our breakout sessions.
Hello. Oh.
Hello.
Hey guys. Hey, Michael. Oh, Michael.
Hey, Ryan.
Hello, everyone.
Hey, Robin.
Hey.
Hey, Robin.
Hey.
Three. I turned the camera on just for you guys. Because who cares?
Oh, you're in a wonderful place.
Yeah, aren't I though? I keep looking at that. I'm like, oh, I wish I were there.
Have we broken up into groups already?
I don't think so because
I don't think so.
This is huge, right?
But it's breaking up now slowly.
Okay.
Okay.
Hi, Paulo.
Hey guys. Who's that?
Barry.
Oh, hey, Barry. I'm so glad to be here with you guys. It's awesome. I think the 15 minutes will be gone.
I think so too.
Hi, I'm so sorry. I was on the phone with a client. Are we in our breakout?
Yeah.
Hi, I'm Michelle. I am a housing case manager with the HOPWA program, and I am at OSA in Pontiac, Michigan.
Hey, Michelle.
Well, do we have a facilitator of this breakout appointed? Because I do have a question, and I don't want to jump in on anybody's. But I thought Paolo's question was really worth talking about a little bit more. If you guys would like to do that, about the undocumented community and how do they fit into any of our policy discussions, really?
Hello.
Hello, welcome back. It's like the Matrix, the way Zoom takes you in and out of these rooms.
I just want to remind everybody to go back on mute now that we're back out of the rooms. There's, 100 and however many of us here again. So
Thank you so much for that, Morgan. And so we have about, I think 20 are missing, so maybe another group is still joining us. And so we had these fabulous conversations in our groups. And as I said before, we would love it if some of the participants from these particular groups can give us a little report back on what was said. And I do not have access to all of your lists and who's raising their hand. So let's do it organically, like we said before. If you were part of the group and you want to share, let's just go right ahead, unmute yourself and share with the group what was talked about in your little breakout session.
Alejandro, we had two folks from our group specifically who were going to talk a little bit about what we discussed. Is that okay?
Of course, awesome. Bring them up.
All right. So I'd like to invite Cordella and Paolo to come up and speak.
Cordella? Well, hey, my name is Paulo. So I work for an HIV behavioral health substance use clinic, and I think some of the things that we talked about is one of them, like inclusion. I think a lot of times there's a lot of communities out there, including like, I always advocate for the Spanish speaking and undocumented communities that are someone not included into these conversations. Like I remember when they had like sessions whenever we have sessions to speak about everything, there isn't a session for the Spanish community. There isn't like Spanish speaking community because of the language situation. So they don't have a voice. So it's important to provide voices to all these communities when it comes to, because honestly, you can't end the HIV epidemic without really addressing the needs of every community out there. You can't just leave some communities out. And the second one, it's like, I didn't mention this in the meeting, but the difference between equity and equality, and having equity doesn't mean that, yes, I provide the same service to all communities. That's not what it is equity means, yes, I overcome the barriers of every community so they can access their service, because every community has different barriers. And that's what true equality is. So those are the two things.
Thank you so much, Paolo. Cordella?
Hi, we talked about also building relationships to increase providers or include more providers like pharmacists into HIV care. Of course, the initial part of our conversation talked about the expansion of PrEP through pharmacists in North Carolina. We talked about increasing routine screening opportunities through emergency departments and actually using emergency departments for prescription of PEP. And one of the things that I also typed in the chat and Paulo talked about is, having that space for people who speak a different language to express themselves. And one of the things that we'd like is making sure, there are spaces in the care centers for people who speak a different language to develop their English speaking skills, because that will help them to become better advocates for themselves.
Thank you so much. Dafina, do you want to add anything from that before we move into the Lee's group?
Oh, no, that was great. I will just add that we talked about the fact that it's not always about going to the state house. It is also about recognizing opportunities to be an advocate when it comes to administrative policies, understanding what these hospital policies are, actually talking to the pharmacist, which is talking to people. What a novel idea, and gaining support and allies and that way. So thank you for that.
Thank you so much. Lee, from your group, did you have any designees who would like to share?
We didn't designate anyone. I'm wondering if either Barry or P. Ryan would jump in. Y'all both had some thoughtful things to say. If you had anything you wanted to pass along to the big group.
Yeah, I would, like to, in this time without so much passion, Justin put out a question about unity amongst all kinds of demographics and even HIV and non-HIV people, towards where we have common causes. And, for me as a heterosexual man, there's no space for us. However, people always say to me, well, create your own space, and I don't have enough energy for that, and if I get enough funding for our space, I'm going to open that funding up so that we can talk to everybody and we can do unity. One of my favorite people to go to the Hill to see was John Lewis. He was not a sanitation worker, but he marched with sanitation workers. He didn't ride the bus, but he marched with the people who wanted to get on the bus. And back then there was no separation. It was jobs, peace, and freedom for everybody. Anyway, I said I wasn't going to get emotional, but hey.
Thank you so much, Barry. Let's see from the Morgan group. We have only a couple of minutes left, and I really want to hear from each group at least something.
Well, I've got Ellis, and I'm so sorry. Someone brought up stigma in our group, and we ran out of time, and she was not able to finish speaking. So if you're here still, if you don't mind taking it away.
I was saying that
stigma plays a big role in whatever category that we're advocating for. There are still so many barriers keeping people from going to doctors and clinics in their own communities. Just being out in the public to say, I have HIV, or I'm a drug user, or I need help. And until we can combat this stigma that we're facing, and it's just as much it's just as bad as having HIV or COVID-19 or being an IV drug user, because it's so taboo now. So that's all I had to say.
Thank you so much, Rita. And thank you, Morgan. Can we listen to someone from the group of Christina real quick? And we'll finish up with my group.
Go ahead, Vanessa and Deidre, take it away.
All right, I'll go first. Or Deidre, go ahead. No. Go first and talk about how you were saying about when you were doing your syringe exchange program, not involving the police, because I think that's really important.
Yeah. For ours, so we, hello everybody. I'm from Virginia. If you haven't heard about all the amazing thing happened in Virginia, that's being caused by a group that myself and Cedric Pulliam co-founded, and that is ending criminalization, HIV, and over incarceration in Virginia. So what we had to do, we had repealed, just very briefly, we repealed everything on ours, and including specifically mandatory testing for anyone who's doing work or anything that's drug related. And we had, once we repealed that piece, well, we had it, the folks at B, meaning the sheriff's department, was like, hold on, we don't like this because we need to have this information, meaning what their HIV status was, et cetera. And so pretty much we told them, miss us with that. Because there are proper protocols that every organization, especially dealing with the public, knows about on how to properly deal with folks that have anything that's going on with them. And so instead of mandatory testing in Virginia, if you are charged with any of that, we now have optional testing that folks can opt into. Information will not be shared with the police. It will not be shared with anyone else. And the police cannot ask the Virginia Department of Health for that information for any reason. So we were very adamant about that, about sharing people's information and saying, that ain't no man, sir, no tea, no shit, no. And
well, we need disruptors like these.
with that, look, we're not leaving any community behind. So that's what we were able to work with in Virginia. So thank you all.
Thank you so much. Really quickly, Vanessa.
Okay. So the reason why I wanted Deidre to speak first about the exclusion of police with their syringe exchange programs is because here in Alabama, we've had an SSP bill that's come up in front of the legislature at least like 4 or 5 different times and has gone absolutely nowhere. And one of the beliefs that law enforcement here has is that Narcan is meant for themselves and their dogs, not to administer to someone who is actually overdosing. And then additionally, I, as an individual, cannot give my friend Narcan. Now, if they're overdosing, I can administer Narcan, but I can't give them a sealed Narcan package because that is illegal in the state of Alabama. So a civilian cannot give another civilian Narcan without actually administering it, to prevent or to, reverse an overdose. And that to me is just absolutely insane.
Thank you so much, Vanessa. We have 1 minute left. I would like Reginald to really just share with us from our group a little bit. And then I want to exhort people to visit any of the websites that were shared throughout the chat. Southern AIDS Coalition, North Carolina AIDS Action AIDS Network. Reginald, take it away. See there. Gerald, take it away, Gerald, please.
Okay. Yeah, so pretty much everything everyone is saying is what we talked about. The first group, exactly. I would just let Deidre speak in regards to Virginia. That's what I had talked about for everybody, but you guys talk to her. She knows it. She's been there. But one of the things that weren't mentioned is making sure that we find the local business partners and local government partners, not only our national. We have to think about local, everyone, not national, the local thing. Get down to, with us, get down to Richmond, get down there and talk to them, as well as making sure you have the information that is culturally and linguistically appropriate, making sure that we have that correctly. And the people in Texas already have some things like that. So if we have that corrected, then we can move on, right? So
thank you so much. I really want to remind everybody to center your conversations about people living with HIV and their stories. This is a great, we could be here for another hour. So I really thank you guys for participating and enjoy the rest of your AIDSWatch experience. Thank you, everybody.
Morgan, I just want to throw out there, ECHO has operated off a budget for almost 3 years now. So you can do amazing things for money.
I saw that. That's amazing. I'm so proud of you. That's so incredible.
So hit me up.
It's so good to see you. We're going to be in touch really, really soon. It's so good to see you.
Hey, boo, hey.
And we'll have a great day.
Yes, everyone. Bye-bye.